All right, welcome everyone. We are just coming on live to Facebook, and we have a few people who are joining us on Zoom. Welcome everyone. If you're joining us on Zoom, be sure to keep yourself muted and your camera off just for our presentation, and we will have an opportunity at the end for asking questions. My name is Tova Burstein. I'm Community Engagement Director with FDMAS Alliance, and I'm just going to start us off with some housekeeping. So this is optimizing your in-person and telehealth visits with Doctors Edward Chow and Kelly Wentworth. This is a continuation of our educational webinar series, and you can find recordings from past programs on our website. And we are, as I mentioned, recording today's session and sharing the program afterwards for anyone to access and share freely. Those who've registered ahead of time with email are, as I said, here on Zoom with us, and others are tuning in live via Facebook. We've collected questions ahead of time on our registration form, but we'll also watch for questions on the comments and in chat. At the closeout, we'd really appreciate it if you'd help us by completing a 3-minute post-webinar survey, which will help us show our impact and continue to support webinars like this one. And finally, this programming is made possible by our donors, with special thanks to Ultragenics and our Charlie's Angels monthly giving circle for their support. We're committed to keeping programs like this free, and you can help by making a donation on our website. With that, I'm delighted to introduce our speakers. Dr. Edward Chow is a professor of endocrinology and metabolism and directs the UCSF Metabolic Bone Clinic. His research and clinical interests are in rare bone diseases, including fibrous dysplasia and McCune-Albright syndrome. He also serves on the FDMAS Alliance Medical Advisory Council. And his colleague, Dr. Kelly Wentworth, is an assistant adjunct professor of medicine in the Division of Endocrinology, Metabolism, and Diabetes at the Zuckerberg San Francisco General Hospital, University of California, San Francisco. And both have been the recipients of Team FDMAS's $1 Million Bike Ride Award. We're so grateful to both of you for being here. With that, I will turn it over to you.
All right, well, thank you very much. And first of all, thank you to the FDMAS Alliance for this opportunity for us to present. We were very happy to talk a little bit about this, the topic today about telehealth and what we can do to optimize it. So what we're going to do is actually start with a very brief talk, and we'll go from there, and then we'll save some time at the end for questions. So let me go ahead and get that started. Okay, so again, my name is Ed Chow. I'm at the University of California in San Francisco, as is Kelly Wentworth here at UCSF. We are both part of the UCSF Metabolic Bone Clinic. And what we're going to talk about today is optimizing telehealth and fibrous dysplasia and McCune-Albright syndrome. We have a couple of disclosures. I do receive research grant funding from a number of different sources, including some companies for studies in FOP, as well as some support from the FDMAS Alliance, as well as the $1 Million Bike Ride. So we're very thankful for that. And Kelly also has some disclosures too from her funding sources. None of these pose any conflicts of interest for this presentation, and the opinions presented today are basically our opinions and not that of the FDMAS Alliance. And we wanted to start by also thanking many of the people in our lab and our research teams that have made a lot of our work possible. This includes recent photos of our lab and different members, as well as many collaborators who have been helpful. Okay. So what I wanted to do is to actually start with a patient visit, a hypothetical patient visit. And so you can see, and I try to identify what might not be so ideal. And actually, I need to stop this for the share for a moment and correct one of the sharing settings, but then I will show you this video in a moment. So, okay.
All right. Hi, how are you, Doc?
Hi, Ed. I'm Dr. Wentworth. It's so nice to meet you.
Yeah, it's good to see you too. You know, I'm not totally sure why I'm here. My doctor said something about there's this thing in my head and I just needed to see you.
Yeah, well, my understanding from talking to your physician and from the referral is that you're here because you have a
Hey,
disease
kids,
called
can
fibrous
you not
dysplasia.
eat all of the gummy bears right now? That's really not cool. That's not a good idea. And can you share? Yeah, okay. Sorry about that. Yeah.
That's okay. It sounds like your kids are there.
Yeah, they're doing fine. They're just
Okay.
chowing down on gummy bears, so they'll
Mm-hmm.
be okay.
Mm-hmm. Well, I just wanted to, as I was saying, the reason that I understand that you're here from your physician is that you have a disease called fibrous dysplasia, and that you are coming to us so that we can provide some expert care.
Okay, is that the thing in my head?
Yeah, so you're here because your primary physician had mentioned that you have fibrous dysplasia. Is that something that you're familiar with?
I've never heard of it, so I don't know what you're talking about. All I know is that there's this thing in my head and it kind of hurts and I don't know exactly what to do about it. So I'm hoping you can fix this. So.
Okay.
Oh, by the way, have you seen that
What?
cat video? The one with the cat that sits on top of the Roomba and just sort of like wanders around? Isn't that kind of cool? I can show it to you right now if you want. So
Well, Ed, we only have about 30 minutes, and it's really important to me that we make sure that we address all of your concerns, and that I explain to you a little bit more about what this is that they found in your head. And so I don't think we have time for the cat video right now.
all right. Okay. Well, thank you.
All right. So I think some of you can probably already identify some of the challenges from that particular type of visit. One is that it's distracting. There are kids involved. People are not focused, or the patient was not really focused on the visit because they're looking at the cat video in the background. And there's really no prior prep to understand what the patient wants to get out of the visit, and not sure why someone is there, and not sure what the main takeaway of this visit would necessarily be. So for today's talk, what we wanted to do was to accomplish a couple of things. I'll talk very briefly about the fibrous dysplasia and McCune-Albright's, because I think it's really important to understand the condition and really sort of think about, what are the questions, what are the things that we need to consider. We'll talk a little bit about your medical team and tips for optimizing a clinical visit. And so Kelly will help lead that section of the discussion. And then we'll end with a period of questions and answers. So, if there are specific things that you're interested in, we can try to help provide some ideas in terms of how to optimize your telemedicine visits, particularly with a focus on FD and MAS. For a couple of things, for privacy and safety reasons, we can't address individual medical concerns on today's webinar. The presentation may discuss off-label or investigational therapies, and each patient is an individual, and the discussion and recommendations may or may not be appropriate for you, and so you should discuss these with your physician. Okay, so very briefly, McCune-Albright syndrome can affect many different types of our organs. The classical symptoms that we think about are these cafe au lait skin lesions, or the hyperpigmented skin lesions, the fibrous dysplasia of the bone, and endocrinopathies, where there are changes in hormone functions, such as with pituitary adenomas, growth hormone, and acromegaly, early puberty, thyroid hyperactivity, and increased steroid production, such as in Cushing's syndrome. McCune-Albright's can also be associated with what we call gastrointestinal growth. So these are sometimes growths on the intestine or on the liver, as well as tooth fragility and dental caries. Fibrous dysplasia of the bone, in particular, is one of those conditions that we are very concerned about because it can have pretty significant effects. Sometimes it affects only a single bone, and other times it affects multiple bones. But because of this, whether it's called monostotic, meaning occurring on one bone, versus polyostotic, affecting multiple bones, you get different types of changes. In many cases, it's sometimes asymmetry in a joint or a limb or in the skull. But every patient is an individual because they may have different bones that are affected, and it requires individual assessments and treatments. So many aspects of McCune-Albright's present early in life. Most often, these are definitively managed very early on because some of them can be quite life-threatening. These include things like growth hormone excess, either from pituitary hyperfunction. This can sometimes present later in life and may require medication or medical management. Hyperthyroidism, which may require thyroid hormone replacement, especially after the thyroid has been removed. Adrenal tumors and Cushing syndrome, which can cause imbalances in salt as well as problems with blood pressure. Estrogen-producing ovarian cysts, which may cause intermittent vaginal bleeding and may require lifelong steroid replacement. And then obviously the fibrous dysplasia of the bone, which may involve pain management, orthopedic interventions, treatments for fractures, and treatments for different types of deformities. When we think about doctor's visits in particular, there are a couple of main topics that often come up. These include things like the bone health, managing fibrous dysplasia bone pain, normal aging considerations, things like cancer screening, and just what happens with arthritis, especially if the fibrous dysplasia is broad. And one of the aspects which we'll talk about at the end of this is also assembling your medical care team. So when we think specifically about bone health and fibrous dysplasia, we know that fibrous dysplasia lesions tend to occur relatively early on, and they tend to present themselves over time. But typically by the third decade of life, all of the fibrous dysplasia lesions that are going to develop have been declared. And so you have a pretty good sense of what the distribution will be. At the third decade of life, things tend to stabilize. And so after that, if there's growth of a fibrous dysplasia, there should be reevaluation for different types of triggers, things like growth hormone hypersecretion, or the development of a bone tumor or other type of complication. Fractures can continue to occur even because the fibrous dysplasia bone is weaker than normal. And so fractures can occur at any time and can continue throughout the lifetime. One thing to keep in mind, though, is that patients are still susceptible to other common conditions, things like osteoporosis, arthritis. This can be accelerated because of the different types of bone deformities that may be present. Hearing and vision screening is important to continue in patients with fibrous dysplasia, especially specifically fibrous dysplasia affecting the head, because even small changes, even if there is slow growth, there can be pretty significant effects on both hearing and vision. And dental health can also degrade. So this is especially true if the bone lesions in the jaw are around the teeth. There can be poor integration with implants. Fibrous dysplasia can be associated with tooth fragility and just sort of enamel that isn't quite as strong. And so that there does need to be constant efforts to just make sure that the teeth are clean and that you're at the lowest risk of developing cavities. One of the things that we hear about a lot is bone and skeletal pain, and pain is a major complication for patients with fibrous dysplasia. Fibrous dysplasia can get worse even if the fibrous dysplasia lesion itself doesn't grow, simply by having the lesion rub against a nerve. And so you may need to seek neuropathic pain evaluation and treatment. Sometimes a pain specialist can be helpful, and we'll talk more about that in the second half of the talk. But sometimes PT, OT, and prosthetics can be extremely helpful as part of the pain management strategy, in addition to medications. When the pain changes significantly over a short period of time, it is important to be evaluated to make sure that there's no new fracture. And in some situations, treatment with things like bisphosphonates and other bone medications may be warranted, depending on the position and the type of fracture that might be present. Prosthetics may be helpful. These include things like shoe lifts and things like that, but other types of prosthetics, like for some patients, they may have to have like knee replacements and other types of joint hardware, depending on the type of issues that are present. But a lot of this can be related to things like changes in biomechanics and standing, as well as walking. And so making sure that your team is aware of these risks is really important. The other thing is that in McCune-Albright syndrome specifically, the levels of phosphorus can get very low because of high FGF23. And these low levels can also cause pain. And so being able to manage the phosphorus levels is also really important. And one thing that we've noted, not only for fibrous dysplasia, but for a number of other bone diseases, is that hydrotherapy and physical therapy can be extremely helpful for some patients in terms of helping to manage pain. There are a couple of things that women need to keep in mind specifically for FDMAS. Gynecologic changes are common in women with McCune-Albright's, and these include things like irregular periods or abnormal uterine bleeding, and sometimes infertility, ovarian cysts, and ovarian insufficiency. Spontaneous pregnancy is possible in patients with McCune-Albright's, and so women who are deciding that they don't want to become pregnant should be cautious about that and use appropriate contraception. Changes in fibrous dysplasia related to bone pain can occur during pregnancy, and there's no clear change in terms of bone or pregnancy outcome over time. The other thing that we hear a lot about is cancer screening. So GNS mutations, the ones that cause fibrous dysplasia and McCune-Albright syndrome, are found in other types of cancers, including the thyroid, pancreas, and breast. And the gene is also known to be important for controlling cell replication. Fibrous dysplasia and McCune-Albright syndrome may have a slightly higher risk of thyroid, cervical, breast, prostate, and melanoma cancers. And so, and in addition to that, fibrous dysplasia lesions do also have a rare potential to transform into malignant bone tumors, such as osteosarcomas or chondrosarcomas. And so because of this, we recommend that age-appropriate cancer screening should be done on time and in collaboration with your primary care physician. So making sure that you don't miss those screenings is really important. So as we get older, there are a couple of other conditions that are really important to keep in mind. Osteoporosis is still a major problem for all patients as patients get older. Screening with DEXA scans, if possible, especially in the non-fibrous dysplasia affected areas, is important. You may need to be followed in a specialty clinic. Making sure that you minimize the risks of falls or fractures is really important. And also trying to get as much weight-bearing exercise and maintaining sufficient calcium and vitamin D. Again, pain management is also critical, and so having clinical pain management service at your hospital to assist can be very helpful. We try to minimize the use of opiates as much as possible, but there are a number of different types of alternatives, including topical medications that can be really helpful. And in some situations, mental health support can be actually very beneficial to both pain as well as general well-being. And that's one of the aspects that we want to emphasize too, is that mental health depression, this occurs, and as people change their mobility over time or with chronic illness, it can have a pretty significant impact. And so making sure that somebody on the team is well versed, being able to help address some of these mental health issues is really important. So a couple of other quick considerations. These include hearing loss, again, age-related, and particularly in patients with craniofacial fibrous dysplasia. Making sure that you have audiology involved if this is occurring, I think is really important. Regular vision screening, especially for patients with craniofacial fibrous dysplasia, particularly around the eyes. This regular screening should be continuing throughout the patient's lifetime. And then COVID-19 is obviously a major consideration. We strongly recommend vaccination and masking for all patients with fibrous dysplasia. Patients with back and chest wall fibrous dysplasia may be at higher risk of COVID-19 complications, particularly things like fractures from coughing or difficulty just taking a deep breath. And McCune-Albright's patients, if you're on steroid replacement, make sure you discuss with your primary care team whether you need to have stress dose steroids available in the event of a physical illness, COVID-19 or otherwise. All right, so that's the brief overview about fibrous dysplasia and McCune-Albright syndrome. What I'm going to do now is turn this over to Kelly, who will continue the discussion about how you assemble a medical team and how you can optimize your clinical visits. So Kelly, I think you were going to just share your screen, so I will stop here.
Yes, I will share my screen. Thank you, Dr. Shaw. I'm just confirming that everybody can see that screen. Great, so the next step is discussing how to develop a comprehensive care team, which is really critical when managing fibrous dysplasia McCune-Albright syndrome. And so I've provided here a list of the care team that folks should think about putting together. And this isn't all inclusive, and this may change and vary depending on what your particular needs are. But first and foremost, it's critically important to have a primary care physician who can manage all of your care. And I really sort of consider them as the conductor and of the orchestra that's the rest of the team here. They are really the ones who should be kind of the first point of contact and be able to communicate from a medical perspective with all of the other specialists that are involved. So making sure that you take the time to find a primary care physician with whom you feel comfortable is really important. And then the next person on the team should be a metabolic bone specialist. At UCSF, that's typically either an endocrinologist or a rheumatologist. Both Dr. Shao and I are in the division of endocrinology. And then having an orthopedic surgeon, particularly if you have any fibrous dysplasia lesions that may have fractured or may be prone to fracture, having an orthopedic surgeon who is familiar with fibrous dysplasia and has cared for patients with fibrous dysplasia is really important. As Dr. Shao already mentioned, involving a mental health specialist on the care team can be really important as well, both from a perspective of managing chronic pain, as well as possible depression or anxiety, and just having someone to talk to about the complications of the disease or the day-to-day management. A pain management specialist is also very important so that you have an extra person on the team who can help with pain management. And as already discussed by Dr. Shao, sometimes it's not the fibrous dysplasia lesion itself that's painful, but perhaps because of a change in mobility, favoring sort of one side of the body versus the other, you may have other pain triggers as well. And a pain management specialist can really help identify those and also treat. Having an eye doctor, particularly one who specializes in the optic nerve, we call those neuro-ophthalmologists. This is really important if you have fibrous dysplasia in the skull or around the eyes or in the face. And so we would always recommend having annual visits with the neuro-ophthalmologist. It's also important to have a good dentist that you can follow. There can be complications if fibrous dysplasia affects the jaw. And so having a dentist who is familiar with fibrous dysplasia and can provide comprehensive dental care would be very important. Okay? And having a palliative care team if needed, or a home health care team can also be very helpful for many patients. And then this is just a note for everybody, for all patients. It's really important to discuss advanced planning, estate planning with family, physicians, tax advisors. This is something that we support in all patients at any age, whether you have fibrous dysplasia McCune-Albright syndrome or not. This is a general recommendation. So there are a few key considerations that are really important to remember. It's important to know that each patient will have individual needs depending on how much their fibrous dysplasia or McCune-Albright syndrome affects them. So every patient is different, will have different needs. So that list of physicians and the care team really should be tailored to individual needs. And you're not alone in this. Your physicians can help to guide management. And I think that that's really where having this comprehensive care team can be very helpful, because you'll have a team of providers who can communicate with each other and with you so that you feel like all of your needs are being addressed. We also want to stress to make sure that you do your regular cancer screening on time as well. Sometimes when people have a disease like McCune-Albright syndrome, fibrous dysplasia, sometimes the actual care, preventive health care and screening can sort of be pushed aside. And so we want to make sure that you still do focus on that as well. And then I think it's very helpful if you can provide all of your treating physicians, everybody on your care team, with a copy of the treatment guidelines, or at least a link to the FDMAS Alliance website, because I think that knowledge and knowing that all of your physicians will have access to that will put you at ease, and will put the providers at ease too, because they'll know that that there's support for them as well. So I want to go through a few ways that you can prepare for a new doctor visit so that you can get the most out of the visit, and so that the provider can give you the best possible care. So these are a few things that can be helpful when you see a new doctor. It's always helpful to know what your current problems are and what your goals are. I always recommend that patients start with that at the beginning, and most physicians will sort of elicit that question from patients. So, what are the concerns that you have today, so that we can make sure that they're addressed. And there will also be questions or concerns that the physician might have, and so it will be a discussion at the beginning about what we can talk about today. It's also important to have the history of your fibrous dysplasia, so how you were diagnosed, any other medical history that you might have, a list of any prior surgeries or biopsy information, whether or not you had genetic testing on the affected tissues, any labs that you had in the past, so that the physician can review those. And I always find this very helpful is if you have ahead of time a CD that has any type of X-ray or CAT scan or radiologic imaging available, ideally already sent to the doctor's office ahead of time so it can be uploaded along with any actual reports. That's very helpful, so the physicians can review that ahead of time. And then finally, having a list of the doctors that you see, anyone who you consider to be on your medical team, as well as their contact information and their fax number for the office, is very helpful. That way we can communicate much more easily. And as I already mentioned, making sure on your first visit that you provide the physician with a copy of the treatment guidelines paper. My experience is that most physicians are very happy to receive those guidelines, and that's they would consider that to be very very helpful. And also, making sure that your physicians know that there are clinical centers with expertise in fibrous dysplasia, in the US and internationally, and that there are physicians that are always available to answer questions should they arise. And I'd also like to mention that even having your history and all of this information prepared on a written sheet of paper is fine too. And many physicians actually appreciate that, so that they can see it and then they can ask follow-up questions. So some guidelines for getting help on specific concerns. What we would recommend is to be really focused, provide a brief overview at the beginning of the visit of your experience with fibrous dysplasia, but make sure that you bring up the issues that are most critical to you so that they can be addressed. So for example, my fibrous dysplasia is doing okay and I don't have changes to my walking, but the pain in my leg is really bothering me, especially in the morning. And I'd really like to make sure that we can address this during this visit. And also make sure that you can provide resources quickly. I think it's always okay to suggest, whether you think that there are certain medications that you could try, particularly if you think that the provider that you're seeing, is not an expert in fibrous dysplasia. And then also asking for things that you might need. So for instance, I'd like to get a referral to a pain management clinic to help with optimizing my pain control. Do you have any recommendations, or can you give me a referral and I'll find a clinic closer to my home? And with that, you can provide a copy of the treatment guidelines as well. And a couple updates on telehealth recommendations. So do make sure that you do your visit from a quiet place. Treat it like it's a regular doctor's visit appointment. From the physician side, we try to do the same thing. We treat these visits as the same as an in-person visit. And so we try to make sure that we have a quiet place that's private with a good internet connection. And I would recommend the same from the patient perspective as well. It's very challenging for you as a patient if you feel like you have distractions in the background as well. We want to make sure that you can, optimally focus and that we can, have a good connection as well. And so moving on to the next thing, make sure ahead of time that all of your technology works. So some hospitals use Zoom or, a hospital or university specific system for the video conferencing. So just make sure that you have those applications downloaded, that you've tried it on your computer or your phone, depending on which one you're going to use, because there can be differences between those applications. And make sure that you have good internet access and that your cell phone signal works. Also make sure that your camera works. Sometimes we get some surprises where we're logging on from a different computer and we don't realize that the camera is not working. And then finally, please don't do it while driving. That's not safe. So if you need to take the visit and you're in your car, please make sure that you're not driving at the same time. Okay. And telehealth visits are really a convenient way for checkups, especially when you don't have any really pressing active issues. And so it's a great way. That's a great time for doing telehealth. But as a reminder, there are still some assessments that are really best if they're done in person, either with your metabolic bone specialist or with your primary care. So that includes anything that requires a physical exam. So new pain in different joints, if a thyroid exam needs to be done, that's best to be done in person. And of course, the blood work and the x-rays need to be done in person as well. So sometimes if you're getting those at the same center, it might just be easiest to do an in-person visit as well. And as a reminder, if you do have hearing loss, a telemedicine visit might have its own challenges. So make sure that you have a companion on the call to make sure that you catch anything, or if you need to use a special assistive device, that you have that set up ahead of time as well, so that you can be most productive during the visit. And again, just making sure that you have all of the information on your medical history and your concerns gathered together early, that you have a medication list that's been updated, and a list of your pharmacy information ready as well as any questions that you might have. And many people do ask, what about email or phone contact? So email and phone is really best if you have a simple targeted question that can be answered pretty quickly. We recommend using the encrypted email or MyChart system through whatever your patient portal is. That way everything stays secure. And it's important to remember that these really should be brief questions, non-emergent. If there's anything that you need an answer to, typically they say within 48 or 72 hours, that really is not something that should be done through an email system. And the goal is so that if you have some quick questions, we can answer them pretty quickly without needing to go through a full follow-up appointment. But as a reminder, emails, messages, these are not a substitute for an actual appointment as well. And part of the concern, of course, is that sometimes with email messages, things can be lost or things may not be clarified fully. And so they can be a little bit higher risk if you have more complex issues to discuss. So if you think it will take more than a minute or two, or it's more than a quick question, then I think it's still best to schedule an appointment or a telehealth visit. And even though COVID-19 is now a couple years into the pandemic, it's still having an impact on healthcare access, and many facilities really are still stretched thin. And so there will still be delays in returning phone calls or emails, and probably intermittently there will be delays in getting imaging. So that's just something important to remember as well. And home healthcare might also be limited or delayed or not available in certain areas. So if you're somebody who does need that or requires that, please make sure that you plan ahead. And also, if you need to go to the hospital or you are ill, please go. Don't wait until things get worse. If you've placed phone calls and you haven't heard back and this is something urgent, please just go in person to the emergency room to see someone, and don't delay the much needed medical care. And then just other important tips. As physicians, we find it really helpful if you have a new symptom or a chronic symptom that's changing, that you keep a diary of what your symptoms are, events that might have, or specific triggers, injuries, trauma that might have happened, and include as much detail as you can. Because sometimes what happens is you may come to the appointment and feel like you can't remember all the details. So if you've kept a diary, that can be really helpful. And also make sure that you've identified the question that's the most important for you for the visit, so that we make sure that that absolutely gets addressed. Ensuring that you have family member, a friend, somebody to join you for your visit who can help take notes or maybe ask questions that you weren't thinking of. That can be really important. And also just have someone who's listening and hearing the same information as you. It's also helpful for us to have copies of all of your tests before you come to your clinic visit. So if you just had some lab work or some imaging studies, please just make sure that you do have them sent to us ahead of time so that we can make the most of the visit. And then again, this is just a list of the important contact information that it's helpful for us to have. And many patients already have this updated in their electronic medical record, and that's very helpful. So what are some other things that you can do to really optimize your health? It's really important staying connected to patient groups like the FDMAS Alliance, MAGIC, and NORD. Participating in patient registries when you have the option is also another way that you can participate and give back. Because the information that the clinicians and the researchers learn can help to drive decisions on sort of what they're going to study and what they're going to work on next to help take care of you in the future. And also, we often do get questions about other resources, like support for working with schools, support for working with insurance. And those are also available on the FDMAS or NORD website. So please be aware that those are available as well. And then this is just a list of the treatment guidelines that are available that were published a couple years ago now. And then just a list to the FDMAS Alliance, the provider directory, if you or your physician ever need additional assistance. And now here's a link to what we think is a better patient visit.
Kelly, I think you might have to reshare and select optimize for video sharing, because we actually can't hear the audio on that one. It's at the bottom of your share.
Apologies for that. Okay, so we're going to do share screen, and then
it's a checkbox at the bottom of the share screen.
Share sound, optimize for video clip. Okay.
Doing okay.
Try this again. Is that better?
Yes.
Hi, how are you, Dr. Wentworth? It's great to see you.
Hi, Ed. It's really nice to meet you. I'm Dr. Wentworth. How are you doing today?
I'm doing okay. I'm having some trouble with this fibrous dysplasia that my doctor told me that I should come and see you about.
Okay. Well, thank you so much for coming to see me. As you know, we are, our group here has expertise in fibrous dysplasia management, so you're definitely in the right place. I just want to start by asking you how much you know about fibrous dysplasia and how this is affecting you right now.
Yeah, so I've read a bit about it on the web, through the Fibrous Dysplasia Alliance, as well as some of the treatment guidelines. And I think the main question for me is that I've been having a lot of this pain in my head, and there's a lesion there that I've been told about, but I just don't know whether it's something that I need to be worried about or whether it's going to change over time.
Okay. Do you have any other concerns today that you were hoping that we could address?
I think the other question that I have is that I sometimes get pain in my legs. I don't know exactly whether that's related or whether that's something else that we need to consider.
Okay. Well, I think certainly let's talk about the fibrous dysplasia in your head and then the pain that you're having in your leg as well, because I think that those are two really important things to discuss today. I was hoping that before we talk about that, that you could just provide me just a brief overview on what your experience has been with fibrous dysplasia when you were diagnosed, and how much you know about this disease.
Sure, let me get some of my records.
Okay, so I hope that everybody was able to see in that video that we all did a better job. There were no distractions. The goals of the visit were very focused. It was very clear to the physician exactly what the concerns were, and all of the information was really ready to go. And so I think that is going to lead to a much more productive and helpful televideo visit. So that's everything that we have planned for today. This is our email address here. And we're once again from University of California, San Francisco at the Metabolic Bone Clinic. So I think at this point, Tova, we can turn to you if we want to open up for questions, or if you have any questions from the audience.
Definitely, yeah. So I will be watching for questions in the Facebook comments, and then also if folks who are tuned in to Zoom want to take themselves off mute, you can either put it in the chat or feel free to come in and show your face on the video as well. I'll start with a couple questions that we had come in. The first is, how do I get a CD or imaging? How do I get that? You mentioned like coming to a visit with that stuff. Who do I ask for? Is that something I do via my chart? Is that like physically a CD? What does that look like?
That's actually a really great question. And thank you for asking that, because sometimes it's the logistics that can be the most challenging. So if you know, all you need to do is you go to the place where you had your imaging done, and you can ask to have that put on a CD, and they will do that for you, and then you can physically bring that in. It is also possible when you come to the appointment, you can sign a release of medical information, and then the physicians can work to get that. But I think it usually works much better if you go in and to the site and request that. I don't know if you have any other tips, Dr. Shao.
Yeah, no, that's a very important question. So there are, amazingly, and especially as the number of CD readers and players go down in the world, you may be able to actually download them from certain sites. And so there are sites that allow you to share those links. What we find particularly helpful is being able to transfer the images themselves into our medical record system here, so that in the future we can actually go back and look at things again. And so either having a CD itself, and then you can keep the copy of the CD once that's done, and has been uploaded into the medical records of the other physician, because you might find another physician who would like to see those same images, but sometimes you can also upload them directly to a site. So coordinating with your physician's office is a great way to try to figure out exactly what format and what you need.
So it sounds like, I could, if I knew I was going to see you, for instance, and I had my imaging done in New Hampshire, I could talk with the imaging center here to either coordinate some sort of electronic transfer or get that CD. And then, because you'd also mentioned it's nice to have that beforehand, either drop that off or send that to the place where I expect to be seen.
Yes. Yeah, and that's often valuable, because in some senses, it's especially in conditions where we're looking at like fibrous dysplasia, where we want to know what the changes over a longer period of time. If you have some of that older imaging, that can be extremely valuable for us to tell, is this something that was going on for a long period of time, or is this something new and acute? And so having those images in hand can be extremely valuable.
I know something that we recommend in the toolkit we put out a few years ago was keeping your own record, in addition to making sure that your electronic medical records are accessible, so that you can have those records on hand just in case.
Yep.
And hopefully electronic medical records have made it easier to share it across care teams. Something else I wanted to ask, because I hear a lot on these webinars that we've put together with medical experts like yourselves, that they're very willing to speak with clinicians. I know that a lot of the folks who we work with, they don't live near a clinical research center. And so their doctors, they don't see as many cases. If I wanted, if I felt like my clinician was recommending something that didn't sound the same as what I'd heard in one of these expert webinars, or if, I wanted to connect that clinician, I think as a layperson going into a doctor's office, I would feel unsure of how to suggest that. And, it sounds like you wouldn't offer that unless you really meant you're open to getting clinician questions. Do you have sort of suggestions, and how common is that for how a patient can approach that with their doctor?
It's actually pretty common, I think, for physicians to ask other physicians for help. And there are multiple platforms for doing that. Some of them are online, and some of them are the more traditional ways through, direct phone calls and contact. So I think that if there is a clinician that is nervous or concerned about fibrous dysplasia, the first thing to do is to go to the FD-MAS Alliance's website and look at that list of clinicians that have signed up there and indicated that they have experience with fibrous dysplasia and McCune-Albright. And that can be an extremely valuable resource, first to identify somebody that's near you that may have that expertise, but also to identify the subspecialists that you may want to have your physician reach out to. You can say, hey, well, there's this person, there's this contact information that was on the website. Would you mind reaching out to them for some advice about this?
Mm-hmm. Definitely. Yeah, I want to reiterate just that if a patient or a clinician, especially if you can get your clinician to reach out to the Alliance, we are more than happy to connect you. And certainly, that's something I wouldn't be sure how common it is, but if it is common, that's really good to know. We have a question, somebody asking, what do you think about sharing images with Google Drive?
Google Drive is not secure, and so we don't generally share images through Google Drive. And it's also, we've noticed that sometimes when files are transferred into something like Google Drive or Box or Dropbox, is that key files are missing, or are written onto the CD in such a way that it wasn't copied correctly. And then so those situations, we're often not able to see them. So sadly, the CD is still works pretty well. So yeah.
Sorry, before we get too far away, I do want to mention that we put the clinician database in the chat and in the comments. And if there are clinicians who we don't know about who really who are excellent, providing excellent care for people in the community, we'd love to add them to our database. So please send recommendations to FD-MAS Alliance so that we might add those to the list. Looking at questions that we got ahead of time, one question says, sometimes I feel intimidated by doctors who have clear agenda prior to appointments and they feel they won't acknowledge their thoughts and feelings and experiences. Do you have advice or suggestions for folks who go in and feel, rightfully or not, their perception is they feel they're dismissed?
Yeah, I think that's challenging. And I think, I just want to reflect that while that shouldn't be happening, I understand that that can happen. And I think it's challenging when the appointment times are short, and there's the concern, like, how will everything get addressed? And so, my recommendation is always, just acknowledge that you understand that, we only have a certain amount of time. And so that it's really important to you that, issues 1 and 2 are at least discussed today. And then, the rest of them, that there can be a plan. So I think, advocating for yourself in that way, and recognizing that the visit really is for you. And if there's a sense that the physicians are kind of rushing through, it may be because they have concerns that they want to make sure are addressed too. And so sometimes just saying, these are my concerns. I don't know if you have any other concerns from the physician side to address, and sort of agreeing on that agenda at the beginning. But I do understand that it can be intimidating sometimes. But I think if you set that agenda from the beginning, it can set a good relationship. And of course, if you feel that you're continually being dismissed and that your needs are never addressed, then I think you can always look for another physician if you need, someone who you feel is listening to you. But I find that most of the time, just by outlining what your concerns are and expressing that you understand that there are time constraints, that usually makes the visit go smoothly.
And you mentioned it a couple times during your presentation, but it sounds like bringing in notes ahead of time, if you can bring, medical history notes, and even maybe outlining for yourself your 2 priorities, or making notes on what those are so that you have it written down, can help.
I personally think that that's very helpful. And I think, if you go to a new physician and you have a stack of records like this and you just sort of plop it on the desk and say, here's everything, that can be intimidating for the physician as well. So, but just saying, here are my records and I've done a nice outline here, even if you review it after the appointment, or we can just go through it today, it's here so that we can, I can help guide you, does make it easier. So I do encourage people to write things down and bring that in.
And I completely agree with Dr. Wentworth, and I would add that I think if you approach it from the standpoint of, there's a fixed amount of time to address things, is what would you prefer to use that time for? Is if you can identify the time and say, okay, well, I can help speed up the process of understanding the background by providing the summary, and in exchange for that extra 5 minutes, I can address one more priority item, then that becomes extremely valuable. And so being able to help summarize that in a cohesive way can really help you try to reach your goals in terms of what you need to do. But I think the other thing is that, there are going to be situations where it's very complicated. And giving the clinic a heads up, saying, it's like, I have multiple issues that I'm going to need to talk about. Is it possible to schedule, 2 follow-up, a slot for 2 follow-up appointments instead of 1? That can sometimes be helpful. Sometimes, just being able to even acknowledge this is like, look, I think I would like to address these 2 problems at this visit, and then can I just have a visit in another 2 weeks that I can address these other 2 problems? Those types of things. Those types of strategies can also be extremely helpful.
I think, especially with a condition like FDMAS that is so complicated, for me at least, it can help to write down a summary beforehand, because it will help me synthesize my thoughts so that, it can, if you're living with this, it relates to and is in everything, but writing down that summary sort of helps you get succinct and focus in on those points. So I think that's really, it's a useful exercise to Ed's point.
And even
sort of optimizing time.
And even sending that ahead of time, if it's a new visit and it's a new physician and you have the document prepared of your history and medicines and all of the list of physicians, that's always welcome as well.
Yeah, and including that as part of the referral packet can be very helpful.
And is that something you could send in again, like via the MyChart?
Sometimes, those electronic charts, typically you have to have a relationship with the provider first before you can send a message. So sometimes for the new visits, that's a little bit more difficult. But even just calling the office beforehand and saying, hey, I have this medical summary that I would like to get to the physician prior to my first visit. What's the best way to get it to you? There's usually a way.
A couple questions here about the care team that we talked about. So this person says, I was curious about the nephrologist point on the slide. Is this related to the high, and I'm sorry, the acronyms are harder for me, alkaline and phosphate levels with
Phosphate.
FD? Is that why the nephrologist does it on here?
Yeah, so so a nephrologist may not be needed for everybody, but for some patients who have high calcium, high phosphorus, or sorry, low calcium, low phosphorus, or actually sometimes high calcium, some of those imbalances, you may need to have a nephrologist involved. It, again, sort of depends on your care team and who's available in your area. I think one of the other questions that had come through was, how important is an endocrinologist in your care? A lot of that really just depends. For some areas of the country or of the world, fibrous dysplasia is managed by rheumatology because they manage bone diseases. In other places, there may be a focus on endocrinology. At UCSF, fibrous dysplasia is part of the metabolic bone clinic, which is based in endocrinology. So it really sort of depends on your individual institution. And a lot of it is that, your primary care physician should be helping to identify, do you need a nephrologist? Do you need an endocrinologist? Are there specific things that you may need at that particular time?
And actually, about that, and the point of do you need an endocrinologist? And that I think was specifically, if I'm only diagnosed with FD versus having MAS. And again, I know you said the primary care physician could help you with this, but how does that endocrinology fit in with somebody who just has lesions?
Yeah, so if you only have fibrous dysplasia, you may not need an endocrinologist. But if you're at UCSF, I guess you'll end up with an endocrinologist because that's where we that's where we see fibrous dysplasia. But again, it depends on the individual institution about how they set up their bone surfaces.
I want to make space here for anybody who hasn't asked a question live before I look at a last question from our pre-registered. Anybody here in person who wants to ask a question? I'm just refreshing here to make sure we're catching people on Facebook. All right, and then, we've talked about this, I think, in many different ways, but several of the questions we got ahead of time just talked about, again, that feeling of being told like, well, this is in your head, or there isn't pain associated with FD. And do you have suggestions of approaches to that, or even phrases that that patients could use to respectfully assert their interests and priorities?
I think that's a great question in terms of certain phrases. And I'll actually have to spend some time thinking about maybe, a good example of sort of how to phrase that and how to ask. I always find that, coming with the toolkit in hand and, the outline of the guidelines and, approaching from a position of curiosity, like, I have these, and it says here that, for some patients, fibrous dysplasia can cause pain. Are you able to just take a look at this, and also to provide, guidance to the, the FDMES Alliance website. But I can understand how that can feel uncomfortable in the moment if you feel like you're advocating for something and you're not being heard and not being appropriately listened to. And I should probably have prepared a better answer for that in terms
No.
of specific words and things that you can use. And so I think that's a good challenge for me personally to be able to sort of reach back out to the community with that information. And I don't know if Dr. Shao has any other ways that he usually counsels folks on that, because it's important. And it's important to feel like your needs are being addressed and that what you're feeling, that you're not told that it's all in your head when there's clear evidence that it's not.
I agree with that. And I think pain in particular is very challenging because there are many things that can cause pain and cause people to sense pain. I think one of the biggest things that we as physicians try to do is to figure out whether pain is being caused by the fibrous dysplasia or whether the pain is actually caused by something else, right? And so I think it is a little bit of a different answer if the answer from the physician is saying that, yes, you have pain, but I don't think it's the fibrous dysplasia versus a failure to acknowledge that there is pain. I think if it's the pain is there, but it's not from fibrous dysplasia, it warrants a search to try to identify what are the other causes of the pain. And so that's a discussion that you would have with your physician to understand. I think if there's a statement that fibrous dysplasia doesn't cause pain, you can say, well, there's actually a lot of studies on fibrous dysplasia about pain and that it is very difficult to manage. And is there a pain clinic that I could talk to? I would be really interested in trying to understand what other options there are for managing the fibrous dysplasia pain. You know, I think just being able to put out options, I think would be good. And I think if there's somebody, in many cases, I think physicians will say, it's just like, oh, well, okay, there is a pain clinic and then I can give you a referral there. I don't know how much good they'll do, but at least you'll have that sort of route and you can sort of start pursuing that particular direction.
Yeah, I think that, and actually I saw on your slides, Kelly, just the idea of like pointing to the research and, you know, like, well, there are studies. And I think even if you didn't bring that research to the visit, either asking to be referred, like Ed mentioned, or sorry, Dr. Shao mentioned, or saying, you know, what can I send in the research article? And that way you can reach back out to the Alliance or look at the resources. And would that be an approach? Could you say, well, I'll send it afterwards via my electronic records now that I have a relationship?
No, absolutely. Sure. Absolutely.
And actually I will there's one more question that came in that I think could be relevant. It says, I was on pamidronate. Sorry, I don't know the PAMIDR. Pamidronate. For over 15 years, my doctor just stopped them. I still have pain. I know you can't answer individual medical questions, but I think, you know, having that feeling of like, well, there's been this change, or this treatment plan has been made and I don't understand it. It doesn't seem to be fixing things. Do you have suggestions for that?
Yeah, that's another great challenge. And I think that's one of those things where I think you just say, you know, I was on it for 15 years and I'm assuming that it may have been helpful during that period of time. It's just like, you know, I'd like to discuss, you know, the decision as to why it was stopped, and you know, if there's an alternative because I feel like my pain is getting worse, right, or something along those lines. And I think just making sure that you open up the conversation, I think, is really important. You know, I would say is that if somebody has been on a bisphosphonate for 15 years, given the new data about the potential toxicities about long-term bisphosphonate use, there is probably some concern about that. And so it becomes a risk-benefit balance discussion, right? And I think that that's important to have with your physician, especially one who may have known you for quite some time, and to understand what those risks and benefits may be.
I think, you know, there's, I think, a much bigger discussion we could have about this topic, and thank you both for being willing to start the discussion. I hope people feel that from everything you've both said, that really to feel empowered, that you should be able to ask if you don't understand what's happening with your treatment plan, to feel that you deserve and you have the right to ask and to understand that. And to know that.
And just to add on that, that is a perfectly valid goal. I mean, you could go into a clinical visit and say, you know, my goal for today is to understand what our treatment plan is moving forward. And that might be it. And that's okay, because I think that that can be very valuable for everybody to just sit down and discuss and not necessarily to focus on one specific issue. So
that's especially as you continue with the care team and have follow-ups.
Yep.
At this point, we are going to wrap up, and I'm so grateful again, Dr. Chow, Dr. Wentworth, for your insight and expertise and for thinking through these difficult topics with us. Thanks also to our donors who made this possible, including Ultragenics and our Charlie's Angels Giving Circle. I'm going to post in the chat the follow-up survey. We really love your feedback. And then finally, I want to invite you to our next event, which is actually a put on sponsored by the Patient Advisory Council, a spooky social with costumes and games and prizes. It's going to be a lot of fun. It's open for all ages on October 22nd. So be on the lookout for that. Otherwise, we're again, very grateful. And we look forward to your feedback. Thank you.
thank you.
Thank you for having us.